You are so warmly welcome to this medical education session. If it's your first time joining us, you're so warmly welcome. It's a pleasure to host you. Medal is an educational community who are passionate about making CME accessible for free to every healthcare professional everywhere. So it's an honor to host you. I hope you find today's session really useful. Before we dive into some incredible education, it's really important that we share our disclosures with you, and I'm going to bring those up on screen for you just now. We're going to cover some incredible topics today. This is the first of a two-part series, and I hope that we begin to set you up for the second part really well. The learning objectives for today's session are to implement evidence-based risk stratification strategies to optimize thrombosis prevention and management in ACS, atrial fibrillation, and secondary stroke prevention, but also to individualize antithrombotic therapy selection and dosing to maximize efficacy whilst mitigating bleeding risks in ACS, atrial fibrillation, and secondary stroke prevention. But before we begin our education, what we like to do is to ask for your opinion on some cases and some polls. And so I'm going to bring some of those up on screen for you just now. And I would love for you to share your thoughts. And guess what? We're going to cover each of these topics in our education today. So I'm going to bring up the first poll, which is this. According to the meta-analysis of 4 major clinical trials, how do direct oral anticoagulants DOACs compare to warfarin for stroke prevention in atrial fibrillation? If you could share your thoughts, A, B, C, D, or E. I'm going to leave that on screen for a little second. I would really love you to tell us what you think the answer is. And if you don't know the answer, it's okay. We're going to cover it in our education today. Okay. Great. Thanks, everyone, for your thoughts. Great. I'll just give you a few more seconds. If you're just joining us, we're doing some polls. You'll find them in the chat box on the right-hand side of your screen if you're on Medal. You'll find them by clicking the little message icon if you're on mobile, and then you'll see all of the polls there. And if you missed the first one, don't worry, you can scroll up and share your thoughts on each of them as we work through. Okay, second poll is this. Based on the 2024 ESC guidelines, what is the primary recommended role for bleeding risk scores like HAS-BLED in managing patients with atrial fibrillation? Is it A, B, C, D, or E? If you could share your thoughts with us, that would be great. Thanks, folks, for sharing your thoughts. I'll just give it a little second. If you're just joining us, we're doing some polls. We are going to work through a couple of case scenarios as well, and then we're going to dive into some incredible education. You can answer the polls on the right-hand side of your screen. Okay, the next poll is this. Regarding DOAC selection, which of the following clinical scenarios is a specific reason to avoid the use of edoxaban? Is it A, B, C, D, or E? I'll let you choose for a few seconds. Great, thank you, everyone. And we're going to move on to our next one, rapid fire polls. Okay, among patients taking apixaban, what is the single most cited reason among patients with poor adherence? A, B, C, D, or E? Be great to hear your thoughts. If you haven't yet answered a poll, you can do it on the right-hand side of your screen on Medal. You can click the little chat icon if you're on mobile, and you'll see all of the polls there. And it'd be great, just scroll up and give us an answer on those polls. This is super helpful for us as well. So it's good to understand where you're at the moment. Okay, and now what I'd love to do is ask for your thoughts on a few cases. So this is the first case. A 65-year-old male with a history of hypertension and type 2 diabetes with non-ST elevation MI. He undergoes successful PCI of the LAD and is found to have a new onset atrial fibrillation. What is his CHADS-VASc score based on the ACC AHA guidelines And what is the most appropriate recommendation for his thromboembolic risk? So what's his CHA2DS2-VASc score and what's the most appropriate recommendation for his thromboembolic risk? I'll give you a few seconds to read that and answer A, B, C, D, or E. Super. Thanks, everyone. Okay. Appreciate you answering those polls. I'll just give you a few seconds, a bit of a longer answer there. If you're just joining us, you can answer these polls on the right-hand side of your screen on Medall. You can click the little chat icon if you're on mobile, and you can scroll up. So if you've missed one, don't worry. Just scroll up and you can answer each of them in turn. Okay. And the next case is this. So I'd love to hear your thoughts on this case. An 82-year-old male with atrial fibrillation is on rivaroxaban. His weight is 58 kilograms and his calculated creatinine clearance is 45 milliliters per minute. He presents with his daughter, who's concerned about his intermittent bruising and history of falls, and asks if his blood thinner should be stopped. What is the most appropriate action that aligns with clinical guidelines? A, B, C, D, or E? You can answer each of these on the chat on the right-hand side. Click the little message icon if you're on mobile. Would love to hear your thoughts before we dive in. If you don't know the answer, don't worry. The whole point is we're going to be covering each of these topics in this educational series. So if you don't know the answer now, hopefully by the end you will. So it's okay. But we'd love to just get you thinking. Okay, the next case is this. This is our penultimate case. A 64-year-old female with a history of end-stage renal disease on dialysis has got atrial fibrillation with a prior stroke and coronary artery disease, and she requires a new percutaneous coronary intervention. She has a documented history of stent thrombosis following cessation of her P2Y12 inhibitor. What is the most appropriate long-term antithrombotic strategy to plan for at discharge? A, B, C, D, or E? Okay, and then we're going to move on to our final case. So we're going to cover each of these topics in our education. So if you don't know the answer, don't worry. And, nothing to worry about. We're going to cover each of these in today's session as well as in our session next week. Okay, final case is this. A 78-year-old male with atrial fibrillation and stable coronary artery disease is seen for a follow-up 1 month after a PCI with a drug-eluting stent. He has a high thrombotic risk, but also an acceptable bleeding risk. He was discharged on a regimen of apixaban, aspirin, and clopidogrel. What is the most appropriate modification to his therapy at this visit? A, B, C, D, or E? If you could share your thoughts, that would be great. Okay. And then great, thanks everyone. Okay. Super. I want to hear how confident you are in 2 areas. One is this. Before we start, how confident are you in implementing risk-based stratification strategies to optimize thrombosis prevention and management in ACS, atrial fibrillation, and secondary stroke prevention? From 5, you're super confident, right down to 1, not confident at all. If you could let me know your thoughts. Okay, super. Okay, brilliant. And final poll, and then we're going to dive into our education, is this. Before we start, how confident are you in your ability to individualize antithrombotic therapy selection and dosing to maximize efficacy while mitigating bleeding risks in patients with ACS, atrial fibrillation, and secondary stroke prevention? 5, you're very confident, right down to 1, not confident at all. Okay, thanks everybody. Brilliant. We have got some really interesting responses Thank you all for answering. We're going to be covering each of these, and we're going to revisit some of these cases at the end as well. So hopefully they'll become clear as we go through. So that gives me great pleasure to introduce our speakers for this evening, and that is Dr. Jennifer Rymer, and she's an interventional cardiologist and also the John Bush Simpson Assistant Professor of Medicine at Duke University School of Medicine, and she's a faculty member at the Duke Clinical Research Institute. And we've also got Dr. Siddharth Patel, and he's Associate Physician in the Cardiovascular Division at Brigham and Women's Hospital, and he's also an instructor of medicine at Harvard Medical School and an investigator in the TIMI study group. And our first speaker for this evening is Dr. Patel, and he is going to be covering how to implement evidence-based risk stratification strategies to optimize thrombosis prevention and management in ACS, atrial fibrillation, and secondary stroke prevention. I'm going to hand over to Dr. Patel.
I'm Sid Patel from the TIMI study group in Brigham and Women's Hospital. And for this session, we'll discuss implementing evidence-based risk stratification strategies to optimize thrombosis prevention and management in atrial fibrillation, acute coronary syndromes, and for secondary stroke prevention. These are my disclosures. So as an overview for our learning objectives, we'll talk about applying some of the clinical risk scores, including the CHADS-VASc, as well as the HAS-BLOOD scores, to accurately identify atrial fibrillation patients at high risk of stroke and to determine appropriate anticoagulation therapy. We'll also utilize validated risk assessment tools to individualize antithrombotic treatment decisions in acute coronary syndromes, as well as secondary stroke prevention. And lastly, we'll touch on improving detection of atrial fibrillation to allow for a timely initiation of anticoagulation. So we'll start with a case of a 65-year-old gentleman with hypertension, diabetes, and hypercholesterolemia, who presents with chest pain and new atrial fibrillation. He's found to have a non-ST elevation MI and undergoes PCI of the left anterior descending artery. So now the questions are, what should his antithrombotic regimen be prior to discharge when he's seen again in clinic, and how should that evolve over the course of subsequent follow-up visits over the course of the next year? And so we'll keep this case in mind as we dive in through the next slides. So I think this is likely no surprise to most practicing clinicians. Atrial fibrillation is by far the most common sustained arrhythmia encountered in practice, with a global prevalence estimated at over 50 million, and with 1 in 3 individuals expected to develop atrial fibrillation in their lifetime. Of course, the most feared complication of atrial fibrillation is the risk of stroke. We know from data dating back several decades that the presence of atrial fibrillation is associated with a 5-fold increase in the risk for stroke, such that beyond rate control or rhythm control, as well as management of comorbidities, anticoagulation really is the mainstay of therapy. We know from data from the era of the warfarin versus placebo-controlled trials that anticoagulation is actually highly effective in reducing the risk of thromboembolism in patients with atrial fibrillation. These are data which pool all of the warfarin versus placebo-controlled trials in atrial fibrillation. And here you can see that warfarin actually resulted in a 64% reduction in the risk of stroke in patients with atrial fibrillation. So warfarin is incredibly effective in preventing the risk of stroke in these patients. So over the last 15 to 20 years, direct oral anticoagulants have really emerged as a preferred option for anticoagulation over warfarin. Not only are they more convenient for patients without the need for routine monitoring, they also have markedly fewer drug-drug or dietary interactions, and they're also incredibly safer. In meta-analyses of the pivotal DOAC versus warfarin trials in atrial fibrillation, the DOACs were proven to be at least as effective for prevention of stroke as warfarin, but importantly, there was a marked 50% reduction in the risk of intracranial hemorrhage, a commonly fatal complication of anticoagulant therapy. It was this reduction in intracranial hemorrhage that actually translated to a 10% reduction in all-cause mortality. The advantage of DOACs for reducing severe types of bleeding is not as evident. While they tend to reduce major bleeding in general, they do increase the risk of gastrointestinal bleeding by 25%. And really that's thought to be because each of the 4 DOACs is actually active within the GI tract, whereas warfarin actually undergoes first pass metabolism within the liver. Of course, clinical decision-making regarding anticoagulation is on the basis of the annualized risk for thromboembolism, and this will vary from one patient to another that has atrial fibrillation. Most are likely familiar with the CHADS-VASc score. This is really the risk stratification tool that's used to determine decision-making around anticoagulants in clinical practice. Here are the components on the left that go into that score. Prior history of heart failure, hypertension, age, whether it be age 65 to 74 years, that gets you a point, or an age above 75 years, diabetes, prior thromboembolism, that gets you 2 points, or a prior vascular disease. Sex category, particularly being female, actually gets you a point within the CHADS-VASc, but there has been a movement away from using this and just going off the CHADS-VA score without the sex category. These are largely felt to be equivalent, given that sex is actually an age-dependent risk modifier as opposed to a intrinsic risk factor. And as you can see, when we apply the CHADS-VASc, there's a stepwise increase in the risk for stroke per 100 patient years. And so you see here on this bar chart that a CHADS-VASc score of 2 or greater translates to an annualized stroke risk of 2% or greater. And really that's the basis that informs the guideline recommendations. So if we look at the clinical practice guidelines for atrial fibrillation, whether the American guidelines or the European guidelines, there's a class 1A recommendation for anticoagulation of patients with a CHADS-VASc score of above 2 in men or 3 or greater in women. Or if you're using the sex agnostic score, just the CHADS-VA, a score of 2 or more in the European guidelines, that isn't sufficient for initiating oral anticoagulation. For patients with a CHADS-VASc score or a CHADS-VA score that's lower, really shared decision-making along with considering other risk enhancers for stroke or systemic thromboembolism is recommended as a 2A recommendation to guide decision-making regarding anticoagulation. Of course, with any anticoagulant therapy, there's always a trade-off in bleeding risk. And to that end, many risk scores have been developed to predict anticoagulant-related bleeding, the most common of which is the HAS-BLED score. Here are all of the components that go into the HAS-BLED score, factors such as hypertension, presence of abnormal renal or liver function, a history of stroke, as well as history of prior major bleeding, a label INR for patients treated with warfarin. And again, the HAS-BLED score was actually specifically developed to predict bleeding for patients treated with warfarin. Age is also a risk factor here, as well as use of alcohol, or drugs which increase the risk of bleeding. And as you can see, the HAS-BLED score actually does a modest job of predicting bleeding in patients treated with warfarin. That's shown here on the right, where you see with higher HAS-BLED scores, there's a higher risk for major bleeding. Given that the majority of patients now, particularly in the United States, are treated with direct oral anticoagulants, the DOAC score was developed to predict DOAC-specific bleeding. But the one thing to emphasize here is that many of the risk factors you see that are specific both to the HAS-BLED or the DOAC score overlap with those used to predict thromboembolism in the CHADS-VASc, right? So factors such as age, factors such as prior stroke or a history of systemic embolism, diabetes or hypertension, that it becomes really hard to separate patients who are high ischemic risk from those who are high bleeding risk. And really that's the reason that clinical guidelines do not recommend the use of bleeding scores to make decisions on starting or withdrawing oral anticoagulation, because the risk factors for thromboembolism and bleeding commonly overlap. And it's also important to note that the sequelae of stroke differ markedly from bleeding, which may be transient, may stop with temporary interruption of anticoagulation or with local measures to address the site of bleeding. However, bleeding risk scores may be useful in assessing modifiable risk factors, such as alcohol, for example, or the use of concomitant antiplatelet therapies that may or may not be indicated. We talked a little bit about the CHADS-VASc as well as the HAS-BLED score, but it's important to note that these risk scores actually have overall quite modest discrimination for predicting who's actually going to go on to have these events. And so newer data has shown that incorporating some of the clinical risk factors we discussed along with cardiac biomarkers that are routinely assessed, such as the natriuretic peptides or cardiac troponin, can actually enhance risk stratification. And further inclusion of novel biomarkers, as well as echo parameters, left atrial size, left atrial strain, really markers that look at atrial remodeling, could improve risk stratification. And so particularly in the era of contemporary electronic health records and advances in machine learning, much of this may make its way into clinical practice in the near future. Switching gears a little bit, it's worth noting that 1 in 4 patients who actually present with a stroke actually have no identifiable etiology. And so a common question that arises is that a proportion of these patients actually have likely occult atrial fibrillation that has never been detected. And so is there a role for mass population screening to detect atrial fibrillation? We mentioned that 1 in 3 will go on in their lifetime to develop atrial fibrillation. And so could a population level screening actually help us to identify these patients earlier and to prompt initiation of anticoagulation? And so this was one of the largest studies done looking at this question, the Apple Heart Study, which enrolled over 400,000 participants without known atrial fibrillation baseline. And these participants underwent smartwatch-based screening with the Apple Watch over a 4-month interval. And what this figure shows you is that the overall yield of atrial fibrillation in the study was actually pretty low overall, right? So just 0.5% over that 4-month interval. Though, as you can see towards the bottom of this figure, there was this age-dependent relationship such that that rate was actually 3% in those aged 65 or higher, suggesting that there may actually be a role for a more targeted screening approach. In the patients who actually screened based on the smartwatch, 34% of those were actually then found to have confirmed atrial fibrillation on patch monitoring. And so really this gets at the question of whether there's a role for targeted screening for atrial fibrillation, and risk scores have been developed to identify patients who may be at higher risk of developing atrial fibrillation. And so one of the most commonly used risk scores, particularly for research applications, is the CHARGE-AF risk score. And this incorporates parameters such as age, race, height, weight, blood pressure, current smoking status, history of diabetes, as well as prior MI. And as you can see on the right, it actually creates a very nice risk gradient for the incidence of atrial fibrillation. And so there may be a role for patients who identify as being at high risk for them to undergo more sort of sustained monitoring, whether with a patch monitor or even a smartwatch-based approach to identify patients who may be at high risk of developing atrial fibrillation, such that that would prompt anticoagulation. But this is not an area that is formally recommended by the guidelines as of yet. Switching gears a bit to acute coronary syndrome, and keeping in mind that first patient that we started with, the patient who presented with a newly diagnosed atrial fibrillation as well as an acute coronary syndrome, we know that these patients are at a high risk for recurrent ischemic events, particularly early on in their trajectory. We also know that these patients who have both atrial fibrillation as well as an indication for antiplatelet therapy are at high bleeding risk. And many of the risk factors that predispose to bleeding are often predictors of atrial fibrillation. And so the question is, how do we optimally manage these patients, balancing the risk of both ischemic events as well as bleeding? And so while traditionally the recommendation was always for dual antiplatelet therapy for 12 months, this becomes a little bit more tricky when patients also have an indication for an oral anticoagulant, as would a patient with atrial fibrillation. And so what the data have shown is that there may be a benefit to de-escalating antiplatelet therapy within 1 to 3 months after the index event, particularly for patients who are high bleeding risk. And so this commonly involves withdrawal of aspirin and continuation of the P2Y12 inhibitor. I'll note here that these data are largely around ticagrelor, which is a much higher potency P2Y12 inhibitor, or prasugrel, whereas the data for clopidogrel are a bit more mixed. And given that that is actually the lowest potency P2Y12 inhibitor, that's really not recommended if using this for a P2Y12 inhibitor monotherapy approach after acute coronary syndrome. Also important to note that the majority of these data are 1 to 3 months after acute coronary syndrome. There was a recent trial looking at even earlier discontinuation of aspirin in patients after acute coronary syndrome. And that actually showed a signal for harm. And so this was the NEO-Mindset trial, which looked at over 3,400 patients with acute coronary syndrome who underwent PCI. And the aspirin was actually discontinued very early. So within the first 4 days, and the P2Y12 inhibitor was continued. Here, that was a higher potency agent, either ticagrelor or prasugrel. And what you can see in these curves is that there was a rate of death, MI, or stroke, or urgent revascularization of 7% in those de-escalating early compared to 5.5% in those continuing dual antiplatelet therapy. So again, a signal for an excess in ischemic events such that this sort of de-escalation should be done probably no sooner than the first week to first month after an ACS event. And that's really where the latest 2025 acute coronary syndrome guidelines have landed. And so I'll draw your attention really to the middle portion of this figure to put this in the context of the case that we started with. And so this is a patient that has an indication for triple therapy. They came in with a non-ST elevation MI and underwent PCI. And they have an indication for an oral anticoagulant because of atrial fibrillation. And so really what the guidelines recommend is discontinuing aspirin no sooner than 1 to 4 weeks post-PCI and undergoing a single antiplatelet therapy regimen along with continuing the oral anticoagulant. Really, that is a strategy to minimize the risk of bleeding in these patients. And so in summary, the CHADS-VASc score helps to risk stratify patients with atrial fibrillation based on the annualized risk of thromboembolism. There's a class 1 indication for anticoagulation if the CHADS-VASc is a 2 or greater, preferably with a direct oral anticoagulant. Bleeding risk scores are helpful to identify modifiable risk factors for bleeding, but should not be used for anticoagulation decision-making, given that the risk factors for bleeding and thromboembolism commonly overlap. And incorporation of biomarkers as well as echo parameters may actually help to improve risk stratification in this area in the near future. Risk scores for incident atrial fibrillation may also help to facilitate targeted screening in selected patients that are at highest risk for developing atrial fibrillation. In clinical risk scores, such as the CHARGE-AF risk score, may be helpful in this regard. And then lastly, de-escalation of antiplatelet therapy in the first month after acute coronary syndrome, particularly in those patients who are at high bleeding risk, may help to reduce bleeding without a clear excess in recurrent ischemic events. But this should be done no sooner than the first week to first month after the index event. And when done, really higher potency P2Y12 inhibitors are preferred for monotherapy. Thank you for your attention.
Thank you so much, Dr. Patel, for a really incredible presentation. We've got some time for questions and answers, and we've got some great questions here for you, and I hope you don't mind us posing them to you.
No, terrific.
We've got some questions on risk stratification strategies to optimize thrombosis prevention and management. The 2025 ESC guidelines give a class 3 recommendation against using bleeding risk scores to decide on starting or withholding anticoagulation. However, with the development of more specific tools like the DOAC score, how should we practically apply this information at the bedside? Does a very high score, for instance, influence your choice of agent dosing or lead you to consider non-pharmacological options like left atrial appendage occlusion sooner?
Yeah, it's a great question. And I think the biggest issue with the bleeding risk scores is the risk factors are almost entirely overlap with thromboembolic risk factors. So if you think about what are the biggest risk factors for stroke, it's advanced age and prior history of stroke. And those are also the 2 risk factors that are in every single bleeding score and weighted the most heavily. And so I think the risk scores I really see as allowing the clinician to hone in on risk factors that may be modifiable. For example, if I have a patient and they're on antiplatelet therapy, what is the indication for this antiplatelet therapy? And do they also need to be on it if they're on a direct oral anticoagulant? Or, can we, through shared decision-making and patient engagement, can we get them to minimize their alcohol use? If they're taking non-steroidal anti-inflammatories for osteoarthritis, for example? Are there alternative sort of multimodal pain regimens where we can get them off doing that, or at least try to minimize NSAID use that's going to increase the risk of bleeding, or potentially prescribe a PPI? And so that's really the way I think of these risk scores. Your point about use of a non-pharmacologic option such as a left atrial appendage occluders, it's an important one. And I think in practice, the way I see or the way that I have approached use of those therapies, it's really for patients that have proven that recurrently to me that they are just at a very high risk of bleeding, or they've had a bleeding in a critical area that is just so high risk that I am a little risk averse to subject them to another trial of anticoagulant therapy. And the reason for that is because certainly these devices do reduce the risk of stroke, but as far as the data show, that does not necessarily reduce the risk to that of an anticoagulated population. And so, and that's also assuming that there's, a proper closure of the left atrial appendage, there's not a residual leak, and all of that goes according to plan. And of course, it's also an invasive procedure that a lot of patients may not want to undergo. And so I think those are sort of the considerations that I'm always thinking through for patients who are at high bleeding risk.
For a patient post-acute coronary syndrome who is identified as having high bleeding risk, clinicians have several de-escalation options, such as dropping aspirin, de-escalating the P2Y12 inhibitor. How do you choose the best strategy for the individual? Is the decision driven by the patient's specific ischemic risk or particular bleeding factors?
Yeah, it's a great question. I think that the field has really shifted over really even just the last 5 to 10 years. Conventionally, patients were always on dual antiplatelet therapy, which consisted of the aspirin, the P2Y12 inhibitor, and it was that we would discontinue the P2Y12 inhibitor and continue the aspirin. But really what the data shows is that the P2Y12 inhibitor may actually be more effective in reducing the risk of recurrent ischemia, more so than aspirin, without really a trade-off in bleeding. And so really the field has shifted towards a P2Y12 inhibitor monotherapy approach. And so if you're doing that for a patient on a direct oral anticoagulant, then we tend to use a lower potency P2Y12 inhibitor, clopidogrel. If you're going to do P2Y12 inhibitor monotherapy without any other anticoagulant, then just given inter-individual variability and some of the ischemic risk signals that we've seen across some of these trials using clopidogrel, we tend to favor a higher potency agents such as prasugrel or ticagrelor.
The guidelines recommend periodic reassessment of stroke risk. What do you consider the optimal real-world interval for recalculating a patient's CHA2DS2-VASc score, and what specific clinical events should prompt an immediate reassessment?
Yeah, it's a great question. I think any clinically evident atherothrombotic event should that automatically puts them in a different bucket. Because those patients are inherently at high risk for recurrence. So that's one. Similarly, I think the same can go for when you're considering the risk trade-off benefit, particularly for bleeding. If a patient was hospitalized with a major bleeding, and that's been a recurrent theme, then that should also prompt the question of some of the non-pharmacologic options that we discussed.
A really interesting final question, if that's okay. So the 2025 ESC guidelines recommend anticoagulation for patients with atrial fibrillation and hypertrophic cardiomyopathy or cardiac amyloidosis, regardless of their CHA2DS2-VASc score. In these specific populations, does the score hold any value, perhaps in quantifying magnitude of their risk or in counseling patients?
It's a great question. And so really the decision to use the CHA2DS2-VASc for atrial fibrillation risk stratification is based on what a patient's annualized risk of thromboembolism is. For patients with hypertrophic cardiomyopathy or cardiac amyloid, these patients are just a much higher risk to begin with, such that the application of the CHA2DS2-VASc score, which is largely just looking at how many other risk factors does this patient have, still identifies a gradient of risk in these patient populations, but their overall risk is just so much higher. such that irrespective of the CHA2DS2-VASc score, these patients should be anticoagulated. And cardiac amyloid in particular is an interesting one because a subset of these patients may actually not have electrical atrial fibrillation, but they may actually have atrial mechanical standstill, which effectively puts them at higher risk for thromboembolism. And so these patients end up just being a much higher risk, such that the CHA2DS2-VASc is now recommended for risk stratification, and that these patients should just be anticoagulated if they have atrial fibrillation.
Dr. Patel, thank you so much for taking so many questions for an incredible presentation. We really appreciate your time.
Thanks so much.
And that just leaves me to introduce our next speaker. But before we do that, I'm just going to pull up a QR code on screen. We're going to be awarding free CME CE certificates for this session. You can claim for the full session or the proportion for which you attended. And to do that, you just need to use this QR code. You can scan it and give us some feedback, and it will then allow you to claim your free CME CE certificate. I've also popped the link into the chat, which will allow you to do the same thing. Okay, I'm going to introduce our next speaker, who is Dr. Jennifer Rymer. And Dr. Rymer is going to be talking to us about individualizing antithrombotic therapy selection and dosing to maximize efficacy whilst mitigating bleeding risks in ACS, atrial fibrillation, and secondary stroke prevention. Dr. Rymer.
Hi everyone, Dr. Rymer, and it's nice to be here today. I'm going to be presenting individualizing antithrombotic and antiplatelet strategies in atrial fibrillation. Here are my disclosures of note. I do have relationships with Chiesi, Idorsia Pharmaceuticals in research investigator purposes. All right, so learning objectives. We're going to individualize antithrombotic therapy selection and dosing to maximize efficacy while mitigating risk. And we're going to focus on coronary artery disease, some other cardiovascular diseases, within a focus on acute coronary syndromes and atrial fibrillation. So one of the big areas to focus on, we have to optimize DOAC dosing and selection to ensure stroke prevention without increasing bleeding risk. That's a big issue for these patients, reducing underuse and inappropriate substitution. We want to address barriers to adherence and improve patient engagement with a specific focus on shared decision-making. So how to talk with patients about anticoagulation and helping them make these decisions. And then we want to reduce inappropriate modifications of anticoagulant therapy due to bleeding concerns. There's a lot of issues around perceived increased bleeding risk, but not also perceiving the patient's thrombotic or stroke risk. So here's a case presentation. So this was a patient I took care of, 64-year-old female with history of ESRD on dialysis, severe peripheral artery disease with multiple interventions, amputation of multiple fingers, toes, secondary to ischemia. She has coronary artery disease and had multiple PCIs or percutaneous coronary interventions, and unfortunately had a prior stroke secondary to her atrial fibrillation. So with previous P2Y12 inhibitor cessation, she's had stent thrombosis, unfortunately. She's failed multiple statins due to myalgias or muscle aches. She came in presenting with chest pain over the past several weeks. She describes chest tightness with any exertion with increasing frequency of occurrence. So here are the presenting angiograms. You can see that both in the LAD distribution and in the circumflex distribution, you can see that there is stent thrombosis or in-stent restenosis, and she has multiple layers of stent in both distributions. And so was having chest tightness, multiple stents already, and I told you already a previous history of stroke, so a high risk of having a recurrent stroke. So tough to figure out what the right regimen for this patient is. I told you she's had recurrent episodes of stent thrombosis, so she may need more potent antiplatelet therapy. Traditionally, we would think about ticagrelor or prasugrel in a patient like this to achieve more potent antiplatelet or platelet rather inhibition. I told you she had atrial fibrillation with the previous stroke history. So she really needs to be on some form of anticoagulation, whether it be warfarin or one of the direct oral anticoagulants continuously. But there may be bleeding with her end-stage renal disease. We know that end-stage renal disease confers a higher risk of both bleeding and thrombosis. So this is an issue to consider. Do we do triple therapy or not? So after I intervene on both her LAD and circumflex arteries, do I put her on aspirin and antiplatelet therapy like prasugrel or ticagrelor that's more potent with an oral anticoagulant? And what kind of bleeding risk does that confer for her? And she needs future surgical interventions. Unfortunately, she was diagnosed with breast cancer and needed a mastectomy. Does she need a cangrelor bridge when she comes into the hospital to wash out the antiplatelet therapies, or can she simply cease the antiplatelet therapy for the requisite number of days prior to her surgery? Does she need heparin? And so I think all of these are very complex decisions to try to make with the patient. And it's not a decision that the provider can make in a vacuum. These decisions need to be made with the patient in terms of shared decision-making, talking to them about the bleeding risk versus the thrombosis risk, and getting a sense for what their preferences for their lifestyle for risk are. And so this was a big consideration for this patient. So atrial fibrillation with concomitant percutaneous coronary interventions and coronary artery disease. These are common issues that I have to talk with the patient about and consider. So when patients come in and they are either on an oral anticoagulant coming into a potential intervention and a need for a heart catheterization, need to think about appropriateness of the PCI procedure, when to perform it. So if they come in and they're still taking their oral anticoagulant, giving a requisite amount of time, if it's not urgent or emergent, to then do the procedure and obtain vascular access. In terms of afterwards, a lot of conversations on what to do subsequently. So if the patient underwent percutaneous coronary intervention and has atrial fibrillation, then you would want to start them back on for a period, what's called triple therapy, which is aspirin and antiplatelet agent, like a P2Y12 inhibitor, and then a direct oral anticoagulant. And so typically we do around a week to a month of triple therapy in patients with concomitant atrial fibrillation with a recent percutaneous coronary intervention. And we do a combination like clopidogrel and apixaban subsequently thereafter. Now, it's very important to make sure that your direct oral anticoagulant is appropriately dosed and that you think about the duration of the need for P2Y12 inhibitor therapy during this time period. So does the patient need it for 6 weeks or 6 months or a year, or potentially if it's an acute coronary syndrome? Those are all considerations that need to be had, as well as thinking about the use of PPIs, so proton pump inhibitors, if you're concerned for the possibility of gastric ulcers. So DAPT, duration and de-escalation. So dual antiplatelet therapy, duration and de-escalation. Nice publication in JACC of 2018, looking at the different duration strategies based on the patient's high bleeding risk. So if they have a high bleeding risk and stable coronary disease, typically you're thinking about potentially ceasing therapy around a month to 3 months, really depending on how severe their bleeding risk is. We don't really use bare metal stents anymore. We primarily use drug-eluting stents. So many of us are comfortable on very high bleeding risk patients that had stable coronary disease, for instance, ceasing the P2Y12 inhibitor at around 6 weeks to 3 months. For patients with no high bleeding risk, you can feel a little bit more comfortable extending for a longer period of time to say 6 months. Now, for patients with acute coronary syndromes, typically you still want to think about, with no high bleeding risk, trying to follow the guidelines with dual antiplatelet therapy out to a year. For those with high bleeding risk, you may be able to consider cessation at 6 months. All of these things and all of these considerations are on a patient-by-patient basis and should be discussed with the patient in terms of their history and potential consequences and mitigation of thrombosis versus bleeding. Atrial fibrillation with concomitant peripheral artery disease considerations. So these patients are at the very high risk. Patients with peripheral artery disease, very high risk of ischemic complications. So those patients with high bleeding risk, you may want to consider antiplatelet monotherapy, either aspirin alone or an agent like clopidogrel alone. If you can accept their bleeding risk, if they have an acceptable bleeding risk, and they have what's called either a high MALE or high MACE risk. So MALE stands for major adverse limb event risk, so risk for future amputation. They have a high major adverse cardiovascular risk. Those patients you may want to consider, for instance, long-term DPI. So that would be an agent like low-dose rivaroxaban. And I use those in many of my patients that have high risk for these cardiovascular events or these limb events. In patients with a lower risk, you may just be able to use antiplatelet monotherapy. The vast majority of those patients, though, with acceptable bleeding risk should be considered for low-dose rivaroxaban in combination with low-dose aspirin. So inappropriate DOAC dosing and outcomes, and this was published now almost 9 years ago. And this was a colleague of mine, Ben Steinberg, looking at the Orbit AF registry and looking at a large population of patients with atrial fibrillation according to how they are dosed. And so recommended dose according to FDA package labeling, underdosing, or overdosing. And interestingly, what we find are those patients that are underdosed or overdosed according to FDA labeling are actually at the highest risk. They're older, they tend to be more likely women, they tend to have a higher CHA2DS2-VASc score, and they tend to have overall a higher risk of having stroke outcomes. And as you can see in the various bars on the right, so about 13 to 14%, the graphic on the left, were actually inappropriately dosed for each of these oral anticoagulants. If you then look on the right in terms of outcomes, you can see that at the recommended dose, you have the lowest risk of these actual outcomes like hospitalization or all-cause mortality. There was a significant increase in all-cause mortality for those patients who were overdosed. There was also a significant risk in terms of all hospitalization for those who were underdosed or overdosed. So really appropriate to try to get the dosing correct. When you have a concern for bleeding risk and you think to underdose a patient, you have to also consider their ischemic and thrombotic risk. So consequences of off-label dosing. This was another analysis, and it looked at apixaban levels. And so these were patients that had on-label dosing at the 5 milligram twice a day dose, on-label dosing at the 2.5 milligram twice a day dose, and off-label dosing at the 2.5 milligram dose. So they were potentially being underdosed. And you can see that the solid bar is basically the median trough level for apixaban. You can see it's significantly reduced for those patients who were given the off-label 2.5 milligram twice a day. And the unfortunate consequences of this are that patients with ischemic risk, with thrombotic risk, with potential for stroke in the future may be well undertreated according to their apixaban levels. And so you may not be getting as much coverage as you think in terms of preventing future stroke by using off-label dosing. So this was a publication of mine back in JAMA Network back in 2023. And so we looked at a large claims data set here in the United States and tried to assess for factors associated with inappropriate DOAC dosing. And in fact, We also showed that the patients that were getting off-label dosing, be it either excess dosing or underdosing, were actually the highest risk patients. They're older, they're more likely to have more strokes, they're actually a higher bleeding risk, and they have impaired renal function. So they're at the highest risk of having poor outcomes. And we showed that the factors associated with underdosing of a direct oral anticoagulant included increase of age, and actually included also the provider's subspecialty. So we found that oftentimes subspecialties or specialties outside of cardiology were more likely to both underdose and overdose patients with atrial fibrillation. Dialysis anemia prior PCI also favored underdosing for reasons you might expect. Now, in terms for favoring underdosing, history of thromboembolism conferred increased risk, and also provider specialty. So this tells me that one of the interesting aspects is that actually the provider's potential awareness around appropriate dosing is a significant factor in what dose patients actually get. Considerations when choosing the correct DOAC dosing, we have to consider low body weight, normal body weight, severe obesity. Important to think about adjusting doses in low or extreme low body weights. As you can see here, for severe obesity, you have to use with caution rivaroxaban and apixaban, as you may not get ideal dosing in patients at the severe extremes of weight. And then considerations when choosing the correct DOAC dosing according to renal function. Very important to consider renal function in these patients because these drugs are largely renally cleared. So if they are at ESRD levels, so creatinine clearance less than 15, typically want to think about apixaban. You want to avoid the others. For creatinine clearance of less than 30, you potentially need to dose adjust rivaroxaban, apixaban, and edoxaban. So great to think about these different renal doses and obesity and low body weights when considering how to dose these medications. And then poor adherence. So one of the issues that we find very commonly is when patients don't really know why they're taking the drug, or they don't think it's important to reduce risk. It's oftentimes hard to explain how a drug might reduce your risk of having a stroke, or what risk really means oftentimes. And so this was an analysis that looked at patients on apixaban and showed that poor adherence, the number couple of factors for poor adherence in patients on apixaban was fear of severe bleeding, lack of symptoms. So they are doing fine. So why take this medication that confers a risk of increased bleeding? And then just simply forgetting to take the medications and having a strategy to remember to take this. Cost also remains a big issue. You need to reevaluate how to improve adherence with each patient encounter. Shared decision-making critical. There's multiple tools out there to help providers in understanding how to make these decisions. It shows the current risk of stroke without anticoagulation, a future risk of stroke with anticoagulation, and helps the patient get a sense of what their actual risk is in a really meaningful way to them, showing the number of patients that will have specific issues if they take medication or if they don't. So really, I try to use these tools in clinic to go over the risk of the patient so that they can better understand it in a graphic manner. And then impact on shared decision-making. So there's been several analyses looking at the impact of these tools on the patient's ability to decide what they're going to do. So this looked at patients before and after having one of these conversations. You can see here after there was increased number of patients that were willing to take the medication because of the discussion. Similarly, there was an increase in the number of patients that said, no, I don't want the medication. And that's okay. As long as the patient has an understanding of their individual risk profile and can state what they do and don't want to do in terms of their health, that's an important step to have with the provider. And you can see less than 2% were unclear as the decision that they would make after those conversations. So quality of care issues remain. I think the perception of risk of falls may outweigh the real risk of unanticoagulated atrial fibrillation. And I think providers are oftentimes concerned in the elderly or frail that there is a real risk of falls, that these medications may be harmful to the patient if they fall, but understanding the risk of a large stroke and what detriment that may have to the patient's life is very important as well. Shared decision-making is critical, but it takes time, and busy clinicians may not always be able to address in short clinics. It's important, though, to try to make time in your clinic to try to have these conversations. It's important to understand concomitant conditions and high bleeding risk in the assessment of antithrombotic and antiplatelet duration in combination. And it's important to constantly reassess patient adherence and persistence and what barriers may exist to trying to improve patient adherence and persistence. Thank you for the time, and I appreciate the opportunity to talk with you all about this important conversation today.
Dr. Rymer, thank you so much for a really amazing piece of education. I am very quickly just going to bring up the QR code so that those of you who are nipping on after 60 minutes can scan that QR code, give us some feedback. Please claim your certificate. Really important for you, and it's really important for us as well to get your feedback. So please scan that. Please give us some certificate. I hope it's give us some feedback. I hope it's been a useful session for you. Okay. I'm going to dive into some questions, and we've got some brilliant questions from our audience across all of our channels, Dr. Rymer, and just thanks again for a really great piece of education. The first question is this that I might ask. In your complex case of the 64-year-old woman with end-stage renal disease, a history of stent thrombosis, AF. You highlighted the difficulty of choosing a regimen. If you were to proceed with PCI, what would your practical day-to-day antithrombotic plan for the first 30 days be? And how would you manage the transition to a long-term strategy given her high risks for thrombosis and bleeding?
Yes, she's a complex patient, but I would say more and more, this is kind of the standard of what we see. And it even becomes more complex when she unfortunately developed breast cancer. And so then there was other considerations when I was about to do her PCI about needing mastectomy and needing surgical planning. But obviously a surgeon is not going to take a patient like this to the operating room with stent thrombosis in her LAD and her circumflex artery. So all of those things were sort of weighing on me. I think for a patient like this, my traditional practice, I would say for patients with concomitant atrial fibrillation, previous strokes, high risk atrial fibrillation with some other risk factor, high CHA2DS2-VASc score, or patients with previous DVTs, they're on current anticoagulation therapy, is I'm doing triple therapy for somewhere between a week to a month, typically. And then I'm dropping the aspirin and proceeding for my patients with sort of standard ischemic risk to clopidogrel and apixaban, typically. There's, I think, most data for that combination. However, in a patient like this, she's had multiple episodes of stent thrombosis. Even while taking her medications, I've looked at her fills. I know she's taking them. And so I actually did ticagrelor apixaban in this particular case after a month-long of triple therapy. And we actually did cangrelor when she came into the hospital because of need for washing out her ticagrelor.
Another interesting question here, which is, Dr. Rymer, you've highlighted the constant clinical tension between preventing thrombosis and causing bleeding. Looking to the future, what is your perspective on emerging therapeutic pathways such as factor 11, 11A inhibition, which aim to uncouple antithrombotic efficacy from bleeding risk? And I guess, could that be the breakthrough we need to finally solve that therapeutic dilemma for our most complex patients?
I think it certainly is an exciting area, and I think we have to wait to see what the trial data and evidence coming out shows. I think there was some early data to suggest there may be some increased stroke risk, but I think we're all sort of very excited to see what this particular area could show in the coming years in terms of data, with Librexia and other trials ongoing, to potentially show data for this therapeutic area in patients that are high risk from both a need for anticoagulation and need for treatment for their ACS. So I think too early to say right now. I'm excited. I can't wait to see what potentially what the evidence shows. But obviously, until we have that, I think too early to say, just given there's been some, like I said, early data around increased stroke risk in some of these drugs.
For sure, that data highly awaited. Uh, Another interesting question. You powerfully demonstrated the value of shared decision-making tools, but also noted the barrier of time in busy clinics. How do we best operationalize that critical process, referring to shared decision-making? Do you recommend a dedicated visit with a pharmacist or a nurse practitioner, or have you found a high yield way to integrate those crucial conversations into that standard 15-minute follow-up?
Yeah, I think it's challenging. I don't think, though, it's a conversation that we can necessarily push off. And so, I just end up doing it. I think there's a lot of good tools online that you can bring up and show sort of uh, pictorial descriptions of risk. And, if you take this medication, there is a risk of, X and 100% of potentially having a bleed, or if you don't, of having a stroke, and having a conversation with the patient about really what their goals are. And I will tell you, and we published on this actually, when patients think about risk and outcomes and what scares them the most, as physicians, we worry about bleeding. We certainly worry about stroke. We worry about death, heart attacks. For patients, when you survey them and say, what is your most feared outcome? We found even more than death, the feared outcome is a lack of functionality. So being alive, but having had a very severe stroke that limits their function, limits their ability to interact. And so, now that I'm sort of equipped with that information, I'm able to really talk about to the patients, and I think a more efficient way about, what scares you the most? What is something in terms of your quality of life? What do you hope to get out of life the most? Are you worried about cost of drugs? Are you worried about risk from drugs? Do you not want to take medications? And just getting at sort of the phenotype of the patient. Every patient is a little different in terms of what matters to them. And so it's important to get to sort of that phenotype of the patient early on, and then I think you can describe risk in a better way to them. It's hard. There's limited time, but I think once you've had these conversations with patients, really you develop a therapeutic rapport, and then it's then, I think, easier to treat them for other processes that come along the way.
I think we've got time to squeeze in one last question, if that's okay. And I'm going to pick this one. For a patient with a documented stent thrombosis event suggesting high on-treatment platelet reactivity, what is your clinical threshold for using a more potent agent like ticagrelor? And how do you balance that decision against the bleeding risk in that shared decision-making conversation?
Yeah, so I think in general practice, it certainly the assays are available, but I think if you look, and we've looked at this in recent data, most institutions are really not checking PRU or platelet reactivity units on all ACS patients or all patients undergoing PCI, so to speak. And so really, if a patient comes back and they have an episode of stent thrombosis, or if they have concern for potential clotting, they have an ACS event while they're on medication, I think certainly my standard, and I think the practice that's really that's supported by the guidelines, is just to go to a more potent antiplatelet therapy like ticagrelor or prasugrel, and not necessarily always test. There's obviously a certain population that's going to have clopidogrel resistance. And certainly you can test for that, but I think that the standard really currently is just to increase the potency of the antiplatelet agent. In terms of increased bleeding, they certainly cause increased bleeding, but for our highest risk patients, I would just say, talking to them and telling them the bleeding is there, the bleeding risk is there, but the ischemic risk is there. And so we wouldn't be starting you on these higher potent antiplatelet agents if we weren't worried about you from an ischemic risk, from a stent thrombosis risk, from a risk of, you came in with a recent stent and now you've had an ACS event or a type 4 MI in your recent stent. So I think they're pretty good conversations to have, but for if there's that increased ischemic risk, I think it's a pretty obvious need for increased potency in your antiplatelet agent.
Dr. Rymer, thank you so much for a really great session. We really appreciate you walking us through such a really great presentation, a great case, and also tackling so many questions. Thank you so much.
Thank you. I appreciate it.
And thank you to you, our audience and colleagues. We're just going to pull that QR code up on screen for you one last time. That will help you to claim your CME certificate. You can scan that. I've placed the link in the chat. You can click on that link and it will allow you to claim your CME certificate after completing a very short form. And that just leaves me to say thank you for coming, for learning with us. I hope it's been useful. We're running another session next week and you'll receive an invitation for that. You'll be so warmly welcome. At that, we're going to be looking at some of the future advances in this space, some of the ongoing trials that begin to solve some of the problems that we've just been talking about. And you will be so warmly welcome at that next session next week. Thank you so much.